So good morning all. Thank you for coming to Symposium. We're looking forward to a great day, and thank you all for coming. So first let me start off by thanking the people who made this possible. A meeting of this size with free registration and tomorrow free tutorials. I don't know how many years we can actually be free, but another year of free, second year in a row of being free is very much appreciated. The Patient-Centered Outcomes Research Institute, PCORIs, under the Eugene Washington Engagement Award, so we very much appreciate them. So I'm gonna and then our sponsors, first Ted Giovannis of the JKTG Foundation for Health and Policy, and then J&J, and then Bayer, Celgene, Pfizer, and Georgia Tech, and the Medical University of South Carolina. So thank you to all of our sponsors. And to our exhibitors, the Hive, Evalitica, and Signet Excel. We've already done a breakdown of our participants, 11 countries, 27 states. The thing I want to point out on this slide, though, and when I was out of the room, did you do where they were, what they represented? It's fairly, but you can see it visually here. Academia, government, and industry, so the blue, the red, and then the multicolors are relatively evenly split, and that's an amazing achievement, actually. So that's what we aim for as stakeholders in this journey that we're on, so we're very happy for that. Our agenda, after my comments, we're gonna have OHDSI's journey through reliable evidence generation. Patrick Ryan doing clinical characterization. You've already met Patrick. We'll have a brief break then. And then Peter Reinbake doing patient-level prediction, and Martijn Schoene doing population-level effect estimation. So those are our three morning plenary sessions. We'll have a lunch, which will go straight naturally into the Collaborators showcase. So that's the time for severe interaction. We have our posters, our demos, and our exhibitors, and that'll be right out in the lobby over here. We'll come back in this room for the community panel on where are we now, with a break, and then a reaction panel on where are we going. We'll do the introductions for those panels later on, and then Patrick will close it at the end. During the course of the year, we did a lot of work on our mission and vision. So, and since we wordsmithed every word, I'm just going to literally read it verbatim. Normally, you're not supposed to read your slides, but given the work we put into it, to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. So that is our mission. And our vision is a world in which observational research produces a comprehensive understanding of health and disease. So this was kind of a broadening and more focused on what really the goal is compared to our previous mission and vision, which was a little bit more mechanical of how we were going to get there. Our objectives, I won't read through this, but just innovation, reproducibility, community, collaboration, openness, and beneficence. This symposium helps us achieve several of them: community, collaboration, and openness. And we take these seriously, and it steers everything that we do. Our collaborators are from around the world. In fact, now we've reached 6 of 7 continents. Actually, we had closely just missed having 7 continents. So the guy from Antarctica who agreed to be on, his time went out and he left Antarctica, and his replacement hasn't been answering literally, this is true, hasn't been answering his email. Now I'm asking myself, what are you doing in Antarctica for 6 months that you can't answer my email message? Are you too busy? And then I came up with it. He brought with him a CD of Hamilton, and he just keeps playing it and playing it. That's like you lose a year of your life, so be very careful if you buy that CD. So what do we do? One way to break up what OHDSI does into these 3 things: clinical characterization, population level estimation, and patient level prediction. Characterization, what is true, what can we count, what can we tally? Population estimation, when it starts getting into correcting for confounders, what is causative? And patient level prediction, on an individual basis, what does this evidence tell me about me? So those are the 3 ways we break it up, and that's really the theme of the morning and the theme of the conference. So you'll be hearing more and more of that as we go on. And so I'm going to go, now last year I went over the data we generated for clinical characterization for treatment pathways. I'm just going to go over it briefly today because part of that feeds into my theme for what I'm saying today, of which I have 15 minutes left. And that is, I timed it knowing we were going to be starting at least 10 minutes late. Today we carry out randomized trials without knowing what is going on in actual practice. We can literally spend $20 million studying a drug, comparing it to the best previous treatment, and it may be no one's using that previous treatment. So what we're doing is we're proving for $20 million that one unused drug can be replaced by another unused drug. First, we should know what's used and have that be as part of the control. Furthermore, why would you carry out a randomized trial nowadays, given the what is available to us, without trying it on an observational basis first? So I think going forward, that there will be no expensive randomized trials without doing a very good observational precursor. It'll be required to characterize the population using the kind of data network that OHDSI has. We'll look at disease burden, treatment practice, time on therapy, complication rate. We do it now through the literature, preliminary studies, but that literature and those preliminary studies are largely in academic medical centers. But we want to know what's actually going on around the community, not just in the academic medical centers. So we looked at treatment pathways. I won't go through the slide in detail, but you see near the middle of the slide is the word guidelines. So guidelines are important and do steer us, but there's a lot of other stuff that goes on, and that's why we need to see what goes on in practice. We can't just predict what is actually being taken. Again, I'm doing a very brief version of the hour talk that I did last year. And just to remind you that we conceived of the thing in November 2014 at the OHDSI Symposium, and within 3 weeks, 7 of our 11 data nodes had returned their final results ready for the paper. So a 3-week time, we carried out a fairly extensive study and had most of that 250 million population that we were aiming for. So it's rapid turnaround that we can do today. And here's one of the slides that I showed. It was published in the PNAS, Proceedings of the National Academy of Sciences, over the summer. On the left-hand side, and we're going to go into depression later on, so I won't cover that. Diabetes, on the depression on the right. On the left-hand side, we have type 2 diabetes. And I'll just remind you that the large green inner circle there is the first drug that you take. It happens to be metformin in the treatment of type 2 diabetes, which is recommended. It is, in fact, carried out about 75 to 80% of the time around the world. But I just want to highlight that graphic on the bottom. That's the Japanese database. And you see that metformin, that green inner circle, is much smaller, that arc, than the rest of it, and then the other 10 that we studied, and all the other countries that we've studied so far subsequently. It just so happens I confirmed this last week. I happened to have a type 2 diabetes researcher, genomics, come and visit me, and to make sure I have this right, but actually she confirmed that the reason is that there is a genetic difference in the Japanese population. They don't get insulin resistance nearly as much as the rest of the world. And so they don't tend to use metformin, they use other drugs. We posited there might be other reasons, like other drugs that are similar to metformin that aren't seen elsewhere around the world, but it's mainly the resistance, and she's actually an MD PhD, so she treats diabetes type 2 and also studies it. So we didn't know that when we went into it, but when we saw this result, we confirmed there was actually a physiologic reason why that metformin is lower. It's not because it's not on the formulary for the government. I think it's actually a physiologic reason. But the reason I bring this up today is to talk about network research, that generating evidence is feasible. And I point out with getting rid of most of the silly duplication, we have 600 million patients in our data network. That still includes a little bit of duplication. Someone at Columbia, it'll be in the Medicare database, but it gets rid of people redoing databases. But if you include the silly duplication, you get up to about 1 billion. And my point then is that's not useful for research, but the work to convert those people, to convert 1 billion people occurred in a voluntary research initiative. If you can convert 1/10 of the world's population's medical records, you can, on a voluntary basis, you can probably convert the rest of the world also. If you can get 1/10, you can get 100%. So it is feasible to convert the entire world's population medical records to a single, very strict data model. So people are afraid, well, it's too much work to convert, to OMOP because you have to get all the vocabularies right, all the mappings. Well, if we can do it for 1/10 of the world on a voluntary basis, we can do it for the whole world. Stakeholders were willing to share results, and we were able to work with vast differences in privacy and research regulation. So now, getting to the theme, just going off and doing a little bit of analogy, I was born in the late 50s. Around then, if I had cancer, I'd have a 90% chance of dying. At that time, doctors with extensive training, vast experience, and strong motivation did the best they could for every single patient. And there weren't a lot of options, and you went to the doctor and you tried to find the best doctor you could find, and they tried to give the best treatment for that kid and give that kid the best chance, and there was only a 10% chance of survival. And that was practicing medicine as an art. And it's around then, late 50s, 60s, that they switched to trying to push most kids into clinical trials and start studying what is really happening here. And they moved from medicine as an art to medicine as a science. And over the next 60 years, it was a slow, painful process. And this is before really genomic medicine. And I know that there were advances, certainly it's a result of advances in pharmacology that allowed us to do this. But the required part was that we treat it as a science and run into clinical trials. And because of that, we slowly got better to where we're now at an 80% cure rate. So my question to you is, where is observational research today? Is it observational research as an art or observational research as a science? So we showed this and some other examples last year. This is bisphosphonates and esophageal cancer, so the same hypothesis, working on the UK GPRD database, or the same database. And in JAMA published in August, with a very good group, a strong group, good training, good experience, and strong motivation, that there was not an association between those two. BMJ, another good journal, the very next month in the same database with another strong book group with good training, good experience, and strong motivation, show that there is an effect. So now what do you do? If just one of these were published, maybe we'd be following along that course. Once two of them come out, then we scratch our heads a little bit. But my biggest concern is no one was overly worried about it. It was just like, this is just how observational research is. And it's time not to accept that this is just the way things are, that we need to figure this out. So please, changed color significantly. Okay, so this is a conceptual diagram, and what I'm trying to, just in words before you look at the figure, what I'm trying to do is say, there's a study and it has an effect. In this case, odds ratio, it's 1.4, which means there's a positive effect. Let's say it's statistically significant. What I want to do is map that on a conceptual space that separates out all the possible populations I could have run that on. So those are different databases. And all the possible methods I could have done and all the possible parameters I could have done. I realize that's not a continuous space, a continuous function, but just pretend you could order them in some enlightened way so the figures would make sense, okay? So it's just a concept now. And so when one study is published, we plot that on the diagram, and then we act as if it's a simple world, as if that JAMA paper came out that I showed earlier, as if that's the truth, and that hopefully over all databases and all methods it would show a similar result. But we all know that the world is not that simple. So I go here. Oh, that slide didn't change color. That's interesting. The blue is statistically significant and the purple is not. You see that the odds ratio towards 1 means no effect. We know that in different populations, I explained about the Japanese population, type 2 diabetes will differ. So this shows us a difference in populations reflected in the databases, but hopefully the methods, and when I say methods here, I'm not including stupid methods. I mean methods that we think work. So these are the range of methods that someone reasonable would apply to the problem. But what I've just shown is that other things can happen. So look at this surface, and then you have statistically significant is blue, in a positive direction, not significant is purple, and statistically significant in the negative direction is green there. And here are the studies we just did. BMJ was positive. For the same database, JAMA was negative. And in another study, not for this particular esophageal cancer, but we've shown in other studies you can actually have opposite directions for the same database, and that's shown between study 3 and BMJ. So you have an epidemiologist who believes that they're, and a statistician, a whole team that believes that they're doing the best work there is, and they have the training, the experience, and the motivation to do it right. They published the first study. And my question to you is, why in these days, when we have this data network, when we have these methods, would you ever want to stop there? Wouldn't you want to know the surface if we have the ability to produce that surface? Like, why would you ever, and why do we need to wait until study 3 occurs to step back from that? When an epidemiologist and a biostatistician say carry out a study, they have an observational research study, they have many, many choices. So imagine they have 100 dials that they can turn. What if it turns out that we look at the surface, so we publish one and it's somewhere, and then I study the surface and it looks like that, and that a slight change of the dial a little bit to the left or a little bit to the right reverses the direction of the results? How much would you trust that? If I'm here, maybe the reason is that they're different populations. And maybe there's a reason behind it that I could figure out. But once I come here, I would start suspecting that there's some problem here and that the variation here says that I don't have evidence. This question just doesn't have evidence right now once I plot this surface. Isn't that something I'd want to know? How do we get here so we can do this? We need to treat observational research as a science. Right now, why are we generating evidence? We're generating evidence because we're trying to tell doctors, don't practice medicine as an art, do evidence-based medicine. But how do we do that? We use an art to generate the evidence so they can practice science. We need to generate that evidence using science also. So what kinds of things am I thinking of? Well, some past studies done by OHDSI and its precursor, OMOP, database heterogeneity, parameter sensitivity. Because if you think about it, what I just described was a sensitivity analysis, right? Empirical performance, empirical calibration is a new method. I won't go through those in details, but that's the kind of thing I'm thinking of. OHDSI is an open science project, so think of it as a vertically integrated structure. So sure, there are software engineers and epidemiologists and biostatisticians, clinical researchers, and people with particular clinical questions, but they're all in service of the bigger goal, open science. We don't want to create standards that don't serve to open science. We want to have everything go towards that bigger goal. So yes, we have a deep information model, and it is some work to convert your data from anywhere around the world into this model that we can share it. And yes, we do help you with 43 extensive vocabularies. And yes, we do create methodologic research, and then we have and turn that into a set of tools and test it on clinical questions. But again, the goal is open science. So the first thing we have to do is admit that there's a problem. We can't go around saying that, we can't hope that each team has done it perfectly. We have to see what the sensitivity is to that perfection. In other words, we have to study it scientifically. We have to define that surface. And some of that surface variation is the truth of how things are. So we need to define the difference between true variation and what's just due to confounding. We need a total description of every study. There's no reason why you should read a paper and it should be ambiguous nowadays, because we're using the same data. If we're both using GPRD, why should I be able to carry out a study and after reading the paper and the methods section and the supplement still not know exactly what they did because some dial could have been a little bit this way or that way? And we have the capability of doing that today, of publishing every last detail of how it's done. And of course we need research into two methods. So that's what the theme is for today, and that's what we'll be showing you in the course, especially starting off in the morning. So that worked out pretty well time-wise. I'm going to be handing it off soon. First of all, thank you to you all for coming. Thank you to our funders, sponsor, and exhibitors for helping us think of how many conferences of this size and magnitude that have free registration. So we're glad to have accomplished that a second year in a row. I want to say thanks to the OHDSI leadership who worked so hard in the coming months to put this whole thing together. To the coordinating center at Columbia, the administrative staff, the students who were out there just manning it last night and this morning, so thank you to them. Thank you to the hotel. Last year they did a spectacular job on the logistics, and looking forward to good logistics so far this year, so they've actually done a very good job. And then I want to single out one particular person, the project manager for OHDSI, Maura Beaton, who many of you have conversed with. When 2 years ago, she thought she was looking for a job, and instead she got a typhoon called OHDSI. OHDSI leadership sat around and said, wouldn't it be fun to have like a 300-person conference? That'd be really neat. But we don't have any money or a conference center. Maura? And so imagine what it takes to put something like this together. Hiring the AV, the place, fundraising, the grant writing, carrying out the grants and the phone calls, emails from you guys about the logistics while you're running OHDSI. So thanking Maura in the course of the day would be very much appreciated. So we ask you to join the journey. You've joined the journey in coming to the symposium. Many of you are part of the community. We look for others to join the community. And I will hand it over to the